Okay, so neoplasia. Kind of a weird picture. You know, here's one finger, another finger that are normal, and then you've got these other three fingers that do this. This is all neoplasia, which includes cancers. So let's get started with this. We showed this picture before. It's basically about the new, or about the cases of cancers. Now these are the new cancers that are here each year. This is from 2015 by the CDC. What I said before is that I want you to know the top three killers, the top three new cases in males and females. In males, it's prostate cancer is number one, lung cancer, and then colon cancer. In females, it's breast, and then lung, and then colon cancer. But if we look at the other thing, the next slide over here, this is going to be the estimated cancer deaths in the United States in 2015. What I showed before was new cases. This is new the number of deaths due to cancers. Now you'll notice that on the males, that the number one killer is, in terms of cancer, is lung cancer, and then prostate went down to number two. In females, you see that it will start off with there's more people with lung cancer that die than there is with breast cancer. So what I want you to actually see is the difference that's going on here. It's not about memorizing all these different things, let alone the percentages. I don't want you to memorize those. What I want you to understand is the concept. Why would you think that, let me go back to this other one, that the new cancer cases, that there's more prostate that we see, and then we see more of the lung cancer, but yet in the cancer deaths, we see more lung cancer deaths than we have prostate. They flip-flop. Why would you think that happens? Well, we pick up new cases because we have screening tests. So in prostate cancer, we have the idea that we could have a PSA test, which is the prostate serum antigen. So there's a chemical that comes out of the prostate, and if it gets too high, then it might suggest that there's some cancer coming from the prostate. And for the breast area, we have the self-breast examinations that we always encourage. And the thing is with self-breast exams, you guys know your own breasts. So if you check your breast once a month in the shower, usually with soap, it's easier to actually feel and palpate any kind of masses there. If you never felt anything there, and all of a sudden you feel like a marble there, or you feel like something as small as like a pea size, and it's something new, you know your own breast. You know, a doctor might miss out on something in doing his examination at when you visit. So you know your own breast. If you have this this marble-like substance that's in your breast for like 10, 20 years, then that's probably you. You know, it's nothing new on that. So that's why it's always good to do a self-breast exam every month in the shower. And us guys, yeah, we got to check our testicles at least once a month to see if there's any issues with that. Also with breast exams, we also have the mammogram. So we have ways that we can pick up cancers much earlier in like first stage. And so people are not dying from breast cancer. People are not dying with prostate cancer. I mean, they are, but lung cancer, there is no screening test. I mean, you could do a chest x-ray, but the chest x-ray is just not going to pick up the early signs, the small masses there. So by the time a chest x-ray is done, if there's lung cancer there, it's already maybe stage 2 or stage 3. At that point, there's going to be an increased risk of death because we're at a different stage. We'll talk about stages later. So that's what I want to bring up that point over there. Okay? Now, these are cancer warning signs. It's a nice mnemonic, caution. Not asking you guys to memorize this. and bleed. That doesn't mean that I want you guys to like cross off and say, hey, Dr. Gamal doesn't want us to know this. That's not the point. The point is, I want you to see this thing. Like if you have a change in bowel movements or change in bladder habits, what that is if you normally poop once a day, and then all of a sudden for the past 3 months, you've been pooping once a week, there's some bowel change there. Now, it doesn't mean that you have cancer, but something's going on. If all your life it was once a day, now it's once a week, something's doing this. So you got to go further testing and see what's going on. So that's why I'm saying, you know, for yourself, for your family, for your friends, if you teach them, because you're a nurse, so they're going to look up to you. And even if in your head, you can ask, you know, if someone in your family thinks they have cancer or feels like they're afraid that there's cancer involved, just do this in your head. Well, ask them, is there a change in bowel habitat? Is there a sore that doesn't heal? These kind of things just help to say, we got to look further. So it's a nice little caution thing. Oh, and also teach your family and friends about this mnemonic. It may save them. So most cancers, not all, but most cancers are prevented. If you think about it, if you know the family history, I mean, if you know that your sister has colon cancer and your mother had colon cancer and your father had colon cancer, you know, that's pretty wise that you should check yourself. And check yourself early so that we can pick it up early, okay? Know your own body. Like I said, do these self-examinations that I just talked about. Know your own body. Get regular medical screenings, colonoscopy, mammograms, those kinds of things, right? Avoid direct sunlight. That's quite obvious. We know that sunlight exposure for long hours can cause skin cancer, okay, even the tanning salons. And watch your diet, watch your weight. We know that having a lot of fatty meals, going to McDonald's, you know, all your life, you know, that can cause colon cancer also. Don't smoke. That's a quite obvious one. Drink alcohol in moderation. We know that some cancers are linked to high alcohol intake, so we just got to be careful with that. So drink it in moderation, if at all, and just stay informed. I mean, if you're finding out later on, you know, like a good example is this. If right now we have these e-cigarettes, and we understand that it doesn't cause any issues. But we don't know if it's going to cause any issues, let's say 10 years down the road, 20 years down the road. So be alert of what's happening in the news. I mean, granted, they had cigarette smoking in the 1800s and the early 1900s. It wasn't until like the 1960s and 70s that it linked cigarette smoking with cancer. So just be alert with the World Health Organization, CDC, and just what people are talking about, you know, on the news and stuff. So just be alert about what's going on. But if you do these things here, it's kind of hard that you're going to get cancer. Or, I wouldn't say get cancer, but it'll be very hard for you to die from cancer because you're picking up these things pretty early. So let's talk about neoplasia. Neoplasia itself means new growth, okay? And an oncologist, someone studying oncology, is really the study of tumors, okay? And in essence, they're really studying the cancer, but oncology is the study of any kind of tumors. And it goes back to mitosis, right? If we have this one parent cell over here, it will make two identical daughter cells. These two cells are identical with itself. This cell is identical with the parent cell. This cell is identical with the parent cell. But if there's some kind of mutation in the process of mitosis, and we talked about things where certain cells go through a high turnover that go through a lot of mitosis, right? Which ones? Right? What was on the test, right? Yeah, the skin cells, right? Skin cells, epidermis, those are the ones that are going to have high turnover cells. There's a greater chance they're going to get mutated, which means there's a greater chance they become cancerous. So what will happen is these cells become mutated, and now this cell will divide into mutated cells and so forth. That's where we have cancers. It all stems because of mitosis. But examples in normal development is that we have, in puberty, we have growth hormone. Remember growth hormone? It comes from the anterior pituitary gland. Growth hormone goes to all the cells and it makes them grow, right? Your thyroid will grow at the same time as your hand, as much as your heart is. They all grow at the same speed, okay? Not so much the same speed, but they're all going to grow, okay? Blood loss, erythropoietin. Have you heard about erythropoietin? Right? You all know what erythropoietin is. Erythro meaning red, poietin is the synthesis of. So this is a hormone. Now just listen to me with this. This is a hormone that gets secreted by the kidney in response to low oxygen levels. When oxygen in your body is decreased, your erythropoietin gets released from your kidneys and it's going to target your bone marrow to make red blood cells. The red blood cells are going to increase, they're going to make more, and then they'll be able to hold on to oxygen more because each red blood cell has hemoglobin. So look up at this picture here. If someone, and this is the type of questions I do ask, okay? I think asking questions like where does erythropoietin come from, the kidney, what's the function of erythropoietin to increase red blood cells? I think questions like that are very kindergartenish, right? You guys are better than that. You're going to have to put things together. And my questions would be, if you have kidney disease, then why would you be anemic? And think about that. If you have kidney disease, a severe kidney disease, why would you be anemic? Yeah, because your kidneys can't make erythropoietin. Now, putting that even further, that when you become a nurse and you're working in intensive care or you're working in a kidney unit, right, with dialysis, you're going to see a lot of patients who have severe kidney disease that's on a medication called Procreate. Procreate is a synthetic erythropoietin. So it's not uncommon. So it's, again, I don't want you to memorize things if you can't. I mean, you don't need to. It makes sense if you understand the mechanism. These people who have bad kidneys, severe kidney disease, can't make erythropoietin, which means they're going to be anemic. So we're just going to supplement them with a synthetic erythropoietin called Procreate. And now they can make red blood cells, and now they won't be so anemic. You've got to put all this together, right? Okay? In adults, you know that muscle cells divide extremely slowly, virtually not even dividing. Like nervous cells don't even divide unless there's certain situations, but very rare that they would divide. Whereas skin cells divide very, very rapidly, have a high turnover. They have a greater chance of becoming cancerous, right? Neoplasm. Basically, there's two features that every neoplasm must have. One is that they must come from a monoclonal proliferation. What does that mean? Okay. What I'm saying with this is that there's going to be one stem cell. Now, let's say there's a bunch of different stem cells over here, right? This one will divide into two of the same stem cells. This will turn into two stem cells. This one will turn into two, not stem cells, but two stem cells, or two cells. This one, in the process of going to mitosis, is going to get mutated. Then these are going to split into two, and they will also be mutated. It all came from one cell. We call this monoclonal. Mono meaning one, comes from the same cell. And proliferation is just a fancy word for multiplying, making more of. Polyclonal means it came from more than one stem cell. But monoclonal, it came from one. So that's one feature that neoplasia must have. It must have monoclonal proliferation. The second feature is just simply that this is going much faster than the other cells over here. It becomes very excessive, the mitosis. And it's unregulated. It just keeps on growing and growing without any control. It's basically uncontrollable mitosis. Okay? But it's mitosis of a mutated cell. Parenchyma is just the cell, it's all of this. It's all of this cells over here. The tumor cells themselves, making them a parenchyma. But we also have the other thing is we have stroma. And stroma is connective tissue that's going to support the parenchyma. Okay? It's going to support it. So basically, it's not the tumor cells themselves, it's the stuff that's going to support it. So a good example of this is that if we have tumor cells, parenchyma, you have tumor cells that are all there, well, it's going to need a lot more blood vessels to give nutrients so that it could actually grow further and further. So you're going to have what we call angiogenesis. Angio meaning blood vessel, genesis is synthesis of. So they aren't cancer. The blood vessels that it's building now is not cancerous, but it's going to support and give into the tumor cells themselves so that the tumor cells don't die off. And there is certain medications that are out there, chemotherapy medications for cancers, that will actually try to destroy these new blood vessel formations. And that's how it would kill the cancer. It's not killing the tumors themselves, but it's going to kill the blood vessels that are giving nutrients to the tumor cells. And then eventually they starve and die. So we did all this before, right? Right? Here's normal cells, here's atrophy, so we decrease in number and size. Hyperplasia is that we increase in cell number only. Here's hypertrophy, where it turns into, where it's going to increase in cell size. Metaplasia is that cells turn into normal cells over here because of a chronic irritation, but these cells are just not in the right place. Right? We gave an example of smoke irritating the trachea, where the pseudostratified epithelium becomes stratified squamous epithelium, many layers, to protect itself from this chronic irritation. But in dysplasia, you have normal cells that turn into abnormal cells. You just can't recognize them. If these are square, now these are going to be more of star-looking, square, let's say, different cells that just don't even make any sense. Rocks, they just don't look anything that we can see. We call them atypical cells. In this case, when the cells turn like that, that's dysplasia. And if this dysplasia happens here where 100% of these cells are abnormal, all of them are abnormal, we call that severe dysplasia, but we also call it is cancer because 100% of them are all atypical. We then call this carcinoma in situ. And you'll see that coming up in the next slide or two. In situ means in place. So it's cancer that's going to stay there. It did not break the basement membrane. When it does break the basement membrane, then you've got invasive carcinoma. So carcinoma in situ is that it stays in place. Invasive carcinoma, it broke the basement membrane and now is spreading. So this is kind of showing you that whole thing. In this case here, you got epithelial tissue up there, the basement membrane's over there, here's a blood vessel. That's a normal situation. Here's where you got dysplasia happening in the epidermis, okay, or the epithelial tissue. If the dysplasia becomes 100%, that they're all dysplastic cells, they're all atypical cells, but yet has not broken the basement membrane, we call that carcinoma in situ. Okay? Carcinoma because it's an epithelial cancer, in situ because it's in place. Okay? This is pre-invasive. It did not break the basement membrane. Once it breaks the basement membrane, now it's invasive carcinoma, and if it enters either the lymphatics or the blood vessels, now we got metastases. Now it's spreading. We call it metastasis. Okay? So you can look over here. Here's mild dysplasia. Here's moderate dysplasia, severe dysplasia. If 100% is all dysplastic, then we call it carcinoma in situ. If it breaks the basement membrane, it's now called invasive cancer or invasive carcinoma. All right. Same way here. This is normal cells over here, and this is a picture of taking a part of the cervix from the uterus, right? The opening to the womb. So here you have normal tissue. Here's mild dysplasia. The cells up here. Here's moderate dysplasia, and here's severe dysplasia. So severe, 100% of the cells. And you can see on here, there's a lot of nuclei that, and the shapes of the cells are nowhere near what it would look like in normal. When you have 100% of the cells that are abnormal in shape and size, atypical cells, we now call that carcinoma in situ, which is severe dysplasia. We got to do something with that, okay? You're not going to have any pictures on your exam. This is just giving an example. It's illustrating what I've been putting it in words for you guys. So let's talk about the molecular basis of neoplasia, right? Well, what happens here is that we have these genetic mutations happening. It's due to some kind of damage to the DNA, whatever it is. Remember, we go back now to cytology, right? The DNA is made up of all those bases, adenine, guanine, cytosine, thymine, right? Those things, you remember those, right? Well, what happens here is that they're all going to be in a certain order. They have to be in a certain order. Otherwise, it's going to be mutated. For instance, if let's say the letters are supposed to be this way. All right, it's like this. Every one of you has a certain image in your head of what that is. Okay? But if we insert something in here and it turns it into this, everyone should have a different image in your head now. It's mutated. It's not what it was originally. If I delete that first letter and you have this, again, you have a different image in your head. If I change something and you have this, you will have a different image in your head. So that's what I'm saying is these letters that you're adding, deleting, inserting, reversing, whichever, they're all mutations. And those mutations can be passed to the next cell every time it goes through mitosis. And if one of those mutations does something to mitosis that it could kick it on even faster, we're going to have some form of cancer. Okay? Anything that's going to cause a mutation is called a mutagen. Smoking is a mutagen. Radon is a mutagen, right? Certain viruses can be mutagens, like HPV, HIV. These can cause cancer. They're going to cause mutations. So cancer is that if the person or that cell is being exposed to that mutagen for an extensive amount of time, then the mutations is going to be so offensive that it's going to keep on producing bad cells, cancer cells, excessively. And that's what goes on with this. A proto-oncogene. A proto-oncogene is a normal gene that's in your body. Even though the word has the word onco, you're thinking cancer. Well, it has something to do with that. But in a normal state, it will work normally. It is just going to make you have, it's going to promote normal mitosis in certain cells. And one of the most popular genes is called the HER2. So whenever you think of HER2 or you read about it, think of it as a proto-oncogene, okay? But this is a normal gene. However, if there's any kind of mutation to that gene, and if the mutation does something so much that it makes that cell go through mitosis excessively, like it turns it on really bad, not just an occasional turn on, it's constantly on. Now these cells are going to be made more and more and more. It's excessive mitosis. In that case, this is cancer. If it gets mutated, we now call the proto-oncogene just an oncogene. So an oncogene is going to cause cancer. A proto-oncogene is a normal thing in the body. Okay? We also have tumor suppressor genes. Suppressor. Suppress is to turn down, right? Is to inhibit, to slow down. So this is a gene that is going to slow down the progression of tumors, or the possibility of a tumor, right? So that's what it's going to do. It's going to inhibit mitosis, suppress mitosis. If it's mutated, it's going to turn off this gene. If it turns it off and it's supposed to suppress it, now it's going to do excessive mitosis, excessive dividing. That can lead to cancer. We also have, this is probably the one of the most famous genes when we're dealing with cancers, but the P53. The P53 is going to promote apoptosis. Remember, it means programmed cell death. So apoptosis is supposed to happen. P53 is going to shut down that mitosis factory. Well, if this gets mutated by any kind of mutagen, radon, smoking, whatever, this could actually turn off that gene and apoptosis doesn't even occur. So that means the cells keep on dividing when they were supposed to be programmed to die. But they keep on dividing excessively. So that would lead to cancer. So what you've got here is oncogenes will turn it on more. This, if it gets mutated, it will turn off. If this gets mutated, it will turn off. You have something that turns on excessively, turns off, turns off. And all three, by these mechanisms, can lead to cancer.